Welcome to the Learn Skin podcast with Dr. Raja and Dr. Hadar, where they discuss all things skin. Skin is fascinating because it affects us in so many ways, like our health, psychology, and how we connect with those around us. This podcast delves into the art and science of skincare. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists. This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learn Skin. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional. This podcast does not constitute medical or other professional advice or services. If you have a medical concern, please consult with your physician.
Hey Raja, how are you today?
How are you, Hadar?
Doing good. You know, I've been thinking about psoriasis, and I see patients with psoriasis all the time, and there are so many questions that come up, especially about biologics as come into practice and how we integrate them as part of a holistic therapy for the patients, and among many others. So I think you told me that we have an expert with us today that can help us sort through this.
Yes, we do. We have Dr. Neal Bhatia. He's a board-certified dermatologist, and he is a psoriasis expert, practices in Southern California. I wanted to welcome you, Neal.
Hi, Neal.
Well, thanks, Raja and Hadar. But if you find an expert, let me know. I want to listen to it.
Well, you know, I don't think we're going to find anyone that's got a bit more experience than yourself, Neal. So, because you do a lot of clinical studies as well, right? In addition to clinical care.
Well, that's the fun part of experience, is bringing things to life and seeing things from start to finish. And that's kind of where research ties in with clinical practice. You kind of see where the development of the drugs, safety assessments, and the way patients respond all kind of in one. And then when the drugs finally make it to market, you can be there and say, well, I saw this come to life.
Yes, that's true. And I wanted maybe just jump straight into it, because one of the common questions that come to my mind when I see patients in front of me with psoriasis is the association of psoriasis with systemic disease. And we know that certainly some parts of it are not new, but we have emerging evidence that keeps coming up about the association of psoriasis and systemic disease. Can you tell us a little bit about that?
Well, I don't think there's any question that inflammatory patterns build on T cell, type 1 immunity and all the cytokines that go with it, including the end effector of tumor necrosis factor, has a lot of impact on all sorts of epithelium, all sorts of muscle tissue. And with that, I mean, that's why we see the impacts on, rheumatological components, on the cardiac muscle, on all of the other metabolic issues that go with psoriasis. And I think, the old days of looking at the outside in really have to give way to looking at the big picture when it comes to how psoriasis affects the patients. Even if we're seeing that patient with 1 or 2% body surface area or small plaques, we have to think in terms of what's going on under the hood, as well as what's going on just on top of the skin. So there are a lot of moving parts when it comes to the immune mechanisms that are making psoriasis, and that's kind of how our pathways of approach from the systemic therapies have really taken hold, especially now that we have some biologics that are really targeted against specific parts. I think we have to really pay attention to the way we are approaching it from the big picture, inside and out.
So perhaps before we actually get to those biologics, maybe you can give us a pearl or two on how this actually affects you in practice. What do you take from those big studies and the mechanistic studies and apply it in your clinic when you see a psoriasis patient in front of you?
I think every dermatologist would agree, whether we're talking about sunscreen, psoriasis, molds, acne, we're just playing a lot of defense. And we have to really kind of brace ourselves for what the patient has already looked up online, so we can be prepared to answer those questions from defense and not actually, think about education. That's what I think has become the hard part about dealing with psoriasis and biologics. The nuts and bolts of it really come back to the old days of music. We used to listen to music on vinyl and 8-track and cassette tapes, and then we had iPods and DVDs, and CDs and more pure forms, and now we have Pandora and streaming and everything else that goes with it. And that's kind of the way we have to explain therapies to patients, that the evolution of treatment has gone from blasting the immune system and trying to make steroids work as quickly and safely as we can, to a lot of, therapies that were almost borderline as chemotherapies and everything else. And now we have targeted agents that are so effective on the process that leave the rest of the immune system intact, that we have to be able to really translate that approach and that safety to the way the patient is thinking about how they're going to have their disease, met. And one of the analogies I use for psoriasis as well as for eczema is the difference between mopping up the mess and turning off the faucet. Because if you look at steroids and anti-inflammatory agents that were once meant to just shut off the immune system, they really were bandages. They were just shutting off the immune process at the end point. And now we have much more targeted treatments that actually turn off the faucet and have much better remission times, as well as treating much more surface area.
Well, Neal, on that note, I think that's a really good segue to actually talk about the new therapies that are coming up. But before we go there, I'd like to say you're absolutely right, because, of the need to make sure that we can keep up with what the patients are reading online. I guess if you can't beat them, join them. That's what we're hoping to do with podcasts like this one. So again, we appreciate getting on too. So if we could talk about the biologics a bit, because that's the new kid on the block. I mean, they're not that new, but they keep having newer and newer agents that come out. Can you just talk about what are the biologic therapies and how are we pushing the borders of immunology and the science that we know about psoriasis?
Well, I think the way biologics have evolved, and again, going back to the analogy of the mopping up the mess, they've gone from targeting the proteins or the cytokines that are actually the effector cytokines that do the cytokines that make the tissue damage, and try to basically kind of counter that swarm, to countering the cell lines that were releasing those cytokines, or even making antibodies that are part of the drug product to the antibodies that we make. And now the steps forward in the way biologics have advanced are much more against the proteins and the cytokines that release the others and cause the other pathways to accelerate. And again, it's just taking things to a level that's so further up the stream that it shuts off that process without affecting the way that other cytokines are doing their job. So one of the and I'm not going to make any endorsements for any drug being better than the other, but one of the drugs that's out there is brodalumab, which works on blocking the receptor of interleukin-17 and its family. And it's not depleting any supply of interleukin-17 or interfering with its way to do any other job. It's just blocking the receptor that IL-17 needs to bind to make psoriasis work. And the rest of the 17 population is intact, right? Same thing with interleukins 23 and that pathway. The pathway that affects the other cytokines that make other immune processes work are not affected when 23 is blocked and another, population of cells or cytokines is not depleted. So it's allowing for your immune system to still be able to do a lot of things like fight off infections and survey for tumors and, other cellular processes, because those cell lines are not being targeted. Only the proteins are.
So do you think the next step would be that we find even more specific pathways, or is the next step would be to improve the delivery instead of injections, moving to pills or maybe spacing out those injections? Where is the next step?
Well, I think we're learning more about pills again, when the old days of pills really were not doing their job for psoriasis. I mean, take, for example, methotrexate and cyclosporin. I mean, these were heavy blockbuster drugs for a lot of diseases, and especially for transplant patients, but it's because of their effect on the immune response, right? It was their effect on suppressing the immune responses for other processes that led to their success in psoriasis, but a lot of that immunosuppression is not necessary from what we found out. So the new wave of drugs, the Janus kinase inhibitors, They go by the term JAK inhibitors for the protein that it basically stops in its tracks. That's probably going to be a new wave of oral medicines that can give an alternative to biologic therapy. But again, the safety profile and the need to do lab tests, we have to really kind of outweigh which one is more important than the other. So like with biologic therapies, we worry about, reactivation of tuberculosis or risks of lymphoma, or risks of some other process that, might be, a result of that depletion of the cell line. The cytokine line. With Janus kinase inhibitors, we have to watch for the blood counts and the lipids and a lot of the testing that was not necessary with the biologic therapies, for example. So there's a bit of a trade-off in the approaches, but again, some patients want a pill, some patients want a shot. We have a lot of patients who don't like to give their own shots. And it's just like patients with diabetes. This is like, in many ways, insulin for their skin, because once they're on, you really don't want to get them off because they'll end up right back where they started.
Well, Neal, I think that's another really good segue, because you're talking about what patients want and, what would work for them. And that kind of leads into the next topic of discussion, which is, when people are looking at an integrative approach, we know now that a lot of people, when they're reading online and thinking about how do I take control of my disease or deal with psoriasis, obviously medications are important, but they're asking a lot of questions around, what are other options that I have? And, I know that we have a few things that we could start discussing, like diet, weight loss, light treatments. How do you incorporate, because we know the biologics are so powerfully good when we previously didn't have these kind of medications available, how do you incorporate that into a discussion where a patient might be thinking about, well, what can I do to be a bit holistic about my approach to psoriasis?
Well, it's an ongoing joke sometimes with patients who seek natural therapies, and not to dismiss it, but patients will say, I want something natural, and the immediate response to them is, well, your disease is natural, and how's that working out? So that's not a nice way of looking at it, but it's also a way of putting it into context that diseases and these processes have to be found, have to have a counter so that they can be put into their proper context or their place. And natural therapies are among us everywhere. Antibiotics are made by bacteria. Our body makes 5 milligrams of steroids every day. And even the biologic therapies to some degree do contain a natural approach in that their antibodies, can either be from human process or synthetic or from animal made. But the point of the exercise is that it's a countering of natural immune processes rather than an ablation of an entire immune response. And that gets a little scientific for patients sometimes. So what I try to tell them is we're trying to counter the natural process in the way that it would be shut down if your immune system could do it on its own. So that's one way of looking at it. But again, in terms of an integration of diet, exercise, again, all of these things come into play with, making sure that, adequate vitamin supplementation is made. Antioxidants can also help promote some of those immune responses to be more effective. And then, of course, we talk about smoking and drinking as really strong immunosuppressants over time. And right. I think that those are a couple of different ways to make sure that, patients with metabolic syndrome potential or psoriasis, patients who are a little bit heavier, for example, those steps are really adequately maintained. I think in terms of vitamin D supplementation, there really hasn't been much proven that it has been effective in psoriasis as compared to what we know about topical vitamin D. But again, if someone is really married to a way that they think they feel better, I don't discourage them that in such a way that says, this isn't going to help you. I just try to remind them that there's that approach is good for you. It's helpful in the fact that you're seeing some outcomes from it, but let's also look at the science behind the disease state and try to put it all into one box.
So Neal, what was really interesting that you said that I wanted to touch upon was, well, first of all, I love the fact that you point out that the psoriasis is a natural process as well. And so we kind of have to look at that imbalance and figure out how are we going to deal with that. You talked about weight loss. There was a really cool meta-analysis that was done 2015 where they looked at several different studies, and they showed that folks that were overweight or obese, when they lost weight, they had a greater chance of an increased odds of almost 3, it was 2.9, of achieving a PASI 75. So, your point about weight loss is a really good one. Do you talk to your patients about strategies for weight loss, or how do you approach that? Because, a lot of the psoriasis patients, I imagine, are overweight or have been dealing with weight-related issues.
Yeah, I mean, it's a bit of a slippery slope, because if someone also has psoriatic arthritis and they're trying their best to exercise, I mean, it's a tough task for many of them. I think again, reminding them about the impact of weight loss and kind of giving them the incentive of how reducing their BMI can really help overall with not just the psoriasis, but the metabolic syndrome potential and everything else that goes with it. I think that's a way to really encourage them. I think, one of the therapies that's often overlooked is metformin, which can have a real impact on their, not only their glucose and triglycerides, but also just the overall warding off of metabolic syndrome while they're trying to incorporate a weight loss plan. And then I think also just in terms of, what are they looking for as comfort? A lot of psoriasis patients, they get anxious and depressed about their disease. They may seek comfort in snacks or, junk food and, or even drinking. And that, I think, might really be something to intervene with.
Yeah, I think that weight loss is such an interesting conversation. So it's always a challenge, especially with smoking and drinking. I think that's a really important point. I mean, Hadar, I don't know what your approach is, but I definitely talk to all my patients about smoking cessation and especially reduction of alcohol intake as well.
Absolutely. Yeah. I make sure sometimes it's even as basic as asking, do you have a primary care doctor? Is there someone that you're seeing regularly to help you manage all this? Or connect to them good nutrition advisor, or even sometimes a social worker that can link them to other services, because it's just awareness is sometimes half the battle. It can seem to a patient, like you mentioned, Neal, that's trying to struggle with psoriasis that covering a good portion of their body, and then psoriatic arthritis, and then trying to get on a medication that's new. And all this is in the middle of just having a life. These are a lot of times young people with a career and kids and on and on. Now you tell them, wait, but you also have to lose weight. You have to stop smoking. You have to stop drinking.
Right.
It seems really overwhelming. So sometimes just that little basic thing of saying, hey, do you have someone who can help you with that? Find that is very useful. Also, it's more practical.
Oh, exactly.
It's more practical as we work in a very busy environment. Usually, we often don't have the time or the privilege of doing that. I would love to sit down for 45 minutes and discuss, various diets that may be of use. It's not the nature of most of people's practice. But the point is
right.
Well taken.
Well, and you get into the patient's psyche also, and they may feel self-conscious about going to the gym, or they're not able to take off their shirts in public, or if they have it on their knees and their legs, they don't want to take off their shorts and be seen. So a lot of it incorporates the whole picture. When patients don't want to exercise, they may get discouraged from even starting a program just because of the impact psoriasis has. I mean, same with swimming. Swimming would be a great exercise for them, but many of them don't want to go into the pool because of the psychosocial components of it.
Right, and I do think that swimming is actually a fantastic intervention for that.
And also, if it's an outdoor
especially
pool.
If there's any, especially if there's any arthritic component also. I mean, that's really something that gets lost with a lot of those patients.
Yeah, and if it's and then a little bit of sunshine never hurt anyone, especially with psoriasis. Too much though can lead to obviously sunburns, which we don't want. So then, Neal, I wanted to transition to talking about the fact that you have two approaches when you see patients. One is as a clinician, a dermatologist, but another one is doing clinical studies. And how are clinical studies different when we think about approaching treatment in comparison to a non-study setting? We would imagine a study is really controlled and whatnot, but I wanted to get your take on it. Since you're seeing patients in both settings, how do you think that the non-study setting is different?
Well, I hate to sound pessimistic, but I think one of the branch points that drives someone into clinical research is lack of health insurance or lack of access to care.
Yeah.
And they come seeking some alternative that was probably not available to them because they'd be out of pocket or they'd be too expensive. That being said, a lot of protocols for these new therapies can be very restrictive. For a lot of topical research, a lot of topical programs in clinical research, they're not allowing to treat the scalp, or there may be less than 10% body surface area, and someone might be too severe. Or the flip side is, if there's over 10% body surface area, and they have nails and scalp or palmoplantar psoriasis, they may actually either be excluded for favor of a different study, or there may be some subset of a study that they could be in that would allow them to be treated with open label. So there's a lot of things that can go plus or minus depending on how much surface area the patient has and which body parts. I think the other thing to consider is how much interest the patient has when they do hear that there's a risk of placebo that's involved with at least some phase of the trial. Now, the majority of systemic psoriasis therapies do involve some open label component, or they at least allow for patients to achieve some level of clearance before they're either taken out of the study or what have you. So looking at it as a researcher means I want to do what's best for the patient as well, given my commitment as a physician, but at the same time, you have to play by the rules. And if the patient doesn't have the criteria, or they don't meet the inclusion or what have you, or even more so if they fail the inclusion because they have a history of latent tuberculosis, for example, or excessive body mass index, that's a very sad way to exclude them. And these are patients who still need help, but if they don't qualify for research, we can't make those exceptions, because it's not the way the game is played.
Right. And I can tell you also, as a clinical trialist myself, and I'm sure, Raja, you would agree, that many times we like to have those patients included in a study, but we can't. But at the same time, I feel that it's a privilege to be a part of the cutting edge, so to speak, and have the patients be a part of it. It's an opportunity. It's, in fact, their right to be a part of innovation. So I think it's a good point, at least for me, to mention that for patients to participate in clinical trials is a privilege, and I welcome other clinicians who are listening to this to refer patients to clinical trials, because we need more patients. We need a heterogeneous population, not just people who are, the usual suspects or people who usually get their care at the university center. And so thank you for making that point, and I second that.
Oh, absolutely. Well, and once those patients do get enrolled in trials, they are the happiest people around. They are excited to be part of creating something new.
Yes.
And, the ones, once they start to see improvement when they didn't have opportunities before, they are just ecstatic, especially, the biologic patients and these new JAK inhibitor study patients. They are just thrilled to see the quality of life that they didn't think they could have had before when they didn't have access to treatment. But they're appreciative that they can be part of something when, for example, a year or so later after the trial, that they hear about the drug that is now on the market. And, we remind them, it's like, you were responsible for helping bring that drug to life. And that's something that they really actually take a lot of pride in.
Absolutely. And so, Neal, you told us a lot of information and really great stuff. I think we learned about how to educate patients as a way to integrate biologics into practice. And I wanted to leave the listeners off with a few practical takeaway about biologic therapies. And if you can tell us a few tips that you find most useful in the day-to-day practice. And also, I'm going to add one more, and that is, what is the intervention that you find that you use the most in addition to biologic? What other intervention do you find most commonly that you integrate?
Well, I'm a big believer in combinations. I have all my patients who end up on biologics on some sort of topical, so that they are treating from outside in and inside out. Especially somebody's going to have a breakthrough, and, I give them something to put on at the first sign of the psoriasis coming back, so they don't feel like they're going to end up back where they started. I think for me to get patients started on therapy really comes back to them understanding the process. And I'm a big believer in mechanism of action. I try to put phrases of mechanisms of psoriasis and match them to the building blocks of how therapies counteract it, so that they understand, kind of the battleground that goes into play. But I also, I remind them about the safety profile, because like I said before, these patients come in with a lot of misconceptions about safety. And I do my best to show them data, show them, what's been published and the truth of the matter, when they've heard a lot of bad rumors, maybe on social media or from somebody who didn't have the medical background. That being said, if a patient really is adamant and does not want biologic therapy, I do my best to try to manage them with some combination of either something systemic. Apremilast has been a good adjunct to a lot of topicals. I've tried to stay away from methotrexate, given a lot of the data that's been published about patients who drink or patients who have fatty liver, and the insidious nature of steatosis, even with normal liver functions. The other thing I also try to do is to see if there is an interest in research. There are a lot of new therapies that are being studied, such as a neurostimulatory device that's similar to a TENS unit. There's also some other combination topicals with vitamin D alone. So I think, there are some research options for those patients who are resistant, but I think for me, the fundamental steps are just translating the science to English and making sure they understand the Legoland and the building blocks that make the disease and the therapy.
Absolutely. Thank you. That was wonderful. And thank you for mentioning the breakthrough in the use of topicals. I think it is often forgotten when we now look at PASI 90 and PASI 100 as the goal, that people do have breakthroughs in even some areas that are resistant. I believe there was just a study that was published showing, for example, the shins is one of the common areas for plaque psoriasis to remain or breakthrough. And it could be really discouraging to a patient who's gone through everything, all the testing, the approval process, and now is using a medication that they think is going to cure them, and they see a small spot and they think, oh my God, is this the beginning of the end? So just to reassure them, give them a topical in their hand and say, you can handle it, don't worry, that's what to expect. I think it's a wonderful tip.
I mean, I try to optimize the resources from the Academy of Dermatology, from the National Psoriasis Foundation. I try to give patients as many links to those websites or pamphlets from them as I can, to at least show them that there's support out there, and it's not just coming from me or from anybody else. It's coming from objective data.
Dr. Neal Bhatia, board-certified dermatologist, we appreciate your time today. And as was mentioned, there are a lot of excellent resources. The AAD has a lot of really good resources on psoriasis. The National Psoriasis Foundation is another really good resource if you're a patient or a practitioner. And with that, we'd like to thank you again for coming on and giving us a bit of your knowledge and wisdom about psoriasis.
Thank you, Neal.
Well, thank you, guys. It was a pleasure, and I'm anxious to hear the next one from you guys. So take care.
Hey, Raja, you know what I'm very excited about?
What's that you're excited about?
I'm excited about the Integrative Dermatology Symposium, the second one coming up on October 3rd through the 5th. This year we have an extra day, and it's going to be in the beautiful Coronado Island Marriott.
There's no question about it. And that program is going to be jam-packed with some really cool stuff. We're going to be talking about case-based discussions with multiple perspectives on things like psoriasis, atopic dermatitis. We'll also have workshops where you'll learn about herbal medicine and think about acupuncture. And so it's going to be a well-rounded program.
Yes, I encourage everybody to go to integrativedermatologysymposium.com to learn more about this great meeting.
Thank you for tuning in with Dr. Raja and Dr. Hadar. This podcast is brought to you by Learn Skin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs. Subscribe today and never miss an episode.